Welcome to The Debate. This program is brought to you by Whole Life Healthcare. Thanks for all our supporters and new subscribers. They are important to this channel. So imagine flipping a light switch in your house. You expect the bulb to illuminate instantaneously, right?
Right, of course. The electrical circuit is closed, the current flows, and the result is immediate.
Exactly. It's immediate. But what if it isn't? What if there's a half-second hesitation before that light comes on?
Well, in a house, you'd immediately suspect a problem in the wiring. Like you'd assume there's some degradation, or a faulty connection, or maybe a failing resistor.
Spot on. And today, we are applying that exact question to human electrophysiology. We're getting into the clinical classification and the physiological reality of first-degree atrioventricular block, or as it's commonly called, first-degree AV block.
Right. And the central tension we are exploring today is whether that terminology, calling it a quote-unquote block, is actually accurate, or if it's, just a relic of outdated clinical naming conventions.
Which it isn't, but sure.
Well, specifically, when we see a PR interval greater than 200 milliseconds on an EKG, are we looking at a true heart block with real pathophysiological consequences? Or is this terminology just a clinical misnomer for what is overwhelmingly a benign conduction delay?
I'll be arguing that it is, in fact, a true heart block. It involves a pathological delay in conduction. It fits perfectly within the established AV block classification system. And crucially, it acts as an indicator of underlying disease. It has documented risks of progression to higher degree blocks.
And I will argue that it is literally just a conduction delay. I'll emphasize that all P waves conduct to the ventricles. No beats are dropped. And it's most often a benign physiological variant, heavily influenced by things like resting vagal tone, rather than actual structural pathology.
Okay, before we get into the weeds of the clinical guidelines, I think we need to establish exactly what this looks like mechanically. So first-degree AV block is defined by an EKG finding where the PR interval exceeds 0.20 seconds.
Right, 200 milliseconds.
Exactly. That interval is the literal time it takes for the electrical impulse to travel from the top of the heart, the sinus node, across the atria, through the AV node, and down the His-Purkinje system to tell the ventricles to squeeze.
Yeah, and the key word there is travel. It gets there. The fundamental issue I have here is semantic precision, because, semantics dictate our clinical approach.
They do.
The term block implies an interruption, a total cessation of flow. But by definition, in first-degree AV block, one-to-one atrioventricular conduction is perfectly maintained. Like every single impulse that originates in the atrium successfully passes down to the ventricles. Nothing is blocked.
I see why you think that, but let me give you a different perspective on why the word block matters mechanically. The old analogy is that if a train is delayed on the tracks aren't clear.
But the train arrives.
It does. But I think a better way to look at it is like a relay race. Imagine a relay race where the first runner hands off the baton perfectly, but the second runner just stands there for 0.2 of a second before taking off.
But the baton isn't dropped. The runner still finishes the race.
They finish the race, but the timing of the entire event is completely thrown out of sync. In the heart, that hesitation causes profound mechanical asynchrony.
Profound? That's a bit strong.
It is profound. The delay between the HO contraction and the ventricular contraction means that the atria finish squeezing, and then there's this abnormal pause before the ventricle squeeze. That hesitation causes the mitral and tricuspid valves to literally close at the wrong time.
Okay, that is a compelling argument, but have you considered what the governing bodies of cardiology actually say about this phenomenon?
I have a feeling you're going to tell me.
I am. If you look at the 2018 ACC-HAHRS guidelines, they explicitly state that first-degree AV block is, and I'm quoting directly here, more accurately defined as atrioventricular delay because no P waves are blocked. The leading experts in the field acknowledge that this historical naming convention is fundamentally flawed.
Well, they call it a misnomer in a purely electrical sense, but they are completely ignoring the mechanical reality of the pump.
They aren't ignoring the pump. They're trying to prevent unnecessary clinical panic. When we use the word block, we create alarm.
Because it's alarming.
No, we take an incidental finding on a routine 12-lead EKG, usually in a totally asymptomatic patient, and we tell them they have a, quote, heart block. Naturally, the patient assumes their heart is failing, when in reality, the electrical signal reaches its destination 100% of the time.
But asymptomatic is doing a lot of heavy lifting for you there. Let's look at what happens in marked first-degree AV block, where that PR interval stretches beyond 300 milliseconds.
Okay, 300 is pretty long.
Right. At that length of delay, the physiological consequences are undeniable. Because the ventricular contraction is so severely delayed, the atria actually end up contracting against AV valves that have completely closed. They are squeezing against a locked door.
Look, I don't disagree that marked first-degree delay can produce symptoms, but you are highlighting the extreme tail end of a distribution to define the whole condition.
But those extreme cases prove the mechanism. When the atria squeeze against closed valves, it drastically increases pulmonary capillary wedge pressure, which is, just a fancy way of saying blood is physically backing up into the lungs.
In severe cases, yes.
Short of breath because their blood is backing up into their lungs, and tell them they merely have a benign delay.
Okay, but let's look at the numbers. The vast majority of PR intervals in this category don't sit at 300 milliseconds. They sit right around 210 or maybe 220 milliseconds.
Sure.
And for those patients, we have to consider that this prolonged interval is often driven by completely healthy, benign physiological factors.
Such as?
High parasympathetic tone. Like when you sleep, your vagus nerve naturally slows everything down. It exerts a negative dromotropic effect.
Meaning it slows down conduction through the AV node.
Exactly. It slows the firing rate down to give the heart more time to fill with blood while you rest. We see this constantly in highly conditioned athletes. Their AV nodes conduct slower because their hearts are incredibly efficient.
I mean, yes, in athletes.
It's also an expected response to medications like beta blockers. Calling it a disease or a block pathologizes a normal, highly functioning physiological state.
That's an interesting point, though. I would definitely frame it differently. You're focusing heavily on reversible or physiological causes, like athletic training. But if someone is listening to this and wondering, why does this matter if the patient isn't an athlete and feels fine? Well, the answer lies entirely in what is happening to the actual muscle of the heart over time.
Oh, here we go, the epidemiology.
We have to look at the epidemiological data, specifically the Framingham study.
The Framingham data is robust, sure, but I think we interpret it very differently.
Well, let's lay out what they actually found. Individuals with first-degree AV block have twice the risk of developing atrial fibrillation. They are 3 times more likely to require a permanent pacemaker, and they face a higher all-cause mortality rate. This isn't just an EKG quirk. It is a marker of danger.
I just come at it from a different way. Correlation is not causation. Is the first-degree AV delay causing the atrial fibrillation, or are both conditions simply covariants of an aging, fibrotic heart?
It's not just a covariant.
It is. The delay is a marker, an incidental byproduct of age, just like gray hair. We don't say gray hair causes mortality, even though it's highly correlated with it in older populations.
I'm not convinced by that line of reasoning at all, because you are completely ignoring the physical mechanism of why that correlation exists. Gray hair doesn't mechanically alter your body. A delayed electrical signal does.
How so? For a mild delay?
We talked about mechanical asynchrony earlier. When the atria are constantly contracting out of sync with the ventricles over a period of years, it causes atrial stretch. The walls of the atria physically dilate and undergo electrical remodeling. That physical stretching is exactly what sets the stage for the chaotic electrical storm of atrial fibrillation. The block creates the environment for the disease.
I'm sorry, but I just don't buy that. Let me tell you why. Let's look at the mechanical echocardiography data.
Go ahead.
A major study in the Journal of Cardiology and Current Research looks specifically at atrioventricular desynchrony. They found that diastolic filling time impairment only really became overt and problematic when the PR interval exceeded 263 milliseconds.
Okay, 263.
So again, for the vast majority of patients sitting at 220 milliseconds, their diastolic filling time is totally fine. Their mitral valve function is fine. Their atria are not stretching to the point of remodeling.
But the fact that a 263 millisecond threshold even exists supports my point.
It proves that once the delay reaches a certain threshold, the mechanical function of the heart is compromised. First-degree block is the foundation of a continuum.
A continuum.
Yes! Second-degree Mobitz type I is the progression. Third degree is the total failure. You cannot just decouple first-degree block from the continuum of conduction disease just because the early stages are mild.
But we must decouple it, because the physiology of a first-degree delay is fundamentally different from the rest of that continuum. Let's walk through what you just mentioned.
Sure.
In second-degree Mobitz type 1, the PR interval gets progressively longer until a P wave is entirely blocked, and a beat is dropped. The circuit physically breaks.
Right?
In third degree, there is complete electrical dissociation. No impulses pass from the atria to the ventricles. The circuit is entirely broken.
Which is exactly why they are higher degrees of the same core problem.
No. First degree is the only condition in this entire classification where the circuit never breaks. That is why the terminology matters. Words dictate action. When a primary care provider sees first-degree AV block on an automated EKG read, they might unnecessarily refer a healthy patient to an electrophysiologist.
Which might be the right move.
Or worse, they might unnecessarily stop a vital blood pressure medication because they fear the word block. If we call it first-degree AV delay, we accurately describe the physiology and prevent algorithmic medical overreaction.
Words do matter, which is why acknowledging the severity of the condition is paramount. The term delay causes dangerous complacency. When we classify it as a block, it forces the clinician to stop, evaluate the patient for symptoms of heart failure, and critically look at the QRS width on the EKG.
Ah, the QRS width. Now we're getting to the anatomy of the situation.
Exactly, because where the delay happens changes everything. A prolonged PR interval is frequently the first visible footprint of progressive fibrosis.
Like Lev's disease?
Right. Lev's disease or Lenegre's disease, the natural scarring of the heart's internal wiring. If a patient has a first-degree AV block and a narrow QRS, the delay is sitting up in the AV node, which acts kind of like a slow toll booth.
The toll booth analogy is fair.
But if they have a wide QRS complex, the delay is infrahisian.
Meaning it's happening below the AV node, down in the bundle branches.
Right. If the AV node is the toll booth, the bundle branches are the high-speed highways leading directly into the ventricles. If the delay is happening in the bundle branches, those highways are crumbling.
That's a dramatic way to put it.
An infrahisian delay carries a remarkably high probability of progressing rapidly and unexpectedly to complete third-degree heart block, which can cause sudden fainting or cardiac arrest. Dismissing first-degree block as a, quote, delay ignores its role as a vital early warning sign of severe structural damage.
Look, you are conflating the PR interval with the QRS width. The progression risk you're talking about is tied almost entirely to the width of the QRS, which indicates the structural heart disease. It's not the prolonged PR interval itself that's dangerous in that scenario. It's the damaged bundle branches. Let's look at the other side of that exact same coin.
Go ahead.
If the QRS is narrow, which is the case in the overwhelming majority of first-degree delays, the conduction slowing is almost strictly localized to that AV nodal toll booth. And the guidelines clearly note that atrioventricular delay at the AV nodal level is associated with a slower, highly stable progression.
Stable, but it still progresses.
It rarely, if ever, progresses to complete heart block unexpectedly. Therefore, the PR prolongation itself is benign. It only becomes a marker of concern if it's accompanied by a wide QRS.
But you can't separate the two. The PR interval is the measurement that tells us the impulse is taking too long from start to finish. Without the prolonged PR interval, we wouldn't have the diagnosis of the conduction disorder to begin investigating. And even if the delay is just in the AV node, if a patient has heart failure, that quote-unquote benign delay can be devastating.
Devastating. How so? If it's just a mild delay, why would it devastate a heart failure patient?
Because of preload. The delayed ventricular contraction creates a negative effect on preload, meaning the ventricles don't get fully primed with that last critical push of blood from the atria before they squeeze.
The atrial kick.
Exactly. For a healthy athlete, losing a fraction of that atrial kick means nothing. But for a patient with a weak, failing heart, losing that optimal filling time means severe decompensation. In fact, if a patient has a prolonged PR interval, a wide QRS, and heart failure symptoms, we actually utilize cardiac resynchronization therapy.
CRT, sure.
We literally implant a specialized pacemaker to override their native delayed conduction and force the heart back into mechanical synchrony. We implant a device to cure their delay. That sounds like a pathological block to me.
That sounds to me like a very specific subset of patients who already have severe structural heart disease. You're taking patients with depressed ejection fractions and using them to define the condition for the otherwise healthy 30-year-old with a PR interval of 210 milliseconds. Context is everything.
I agree, context is everything, but the physiology of the delay is what triggers the intervention.
Well, let's talk about how dynamic that physiology is. Take Lyme disease, for example.
Okay.
If a patient comes in with Lyme disease, they can develop Lyme carditis, an infection of the heart tissue. This often presents as first-degree AV delay. When we treat the Lyme disease with antibiotics, the PR interval returns to normal. It was an inflammatory delay.
Right, it was inflamed.
Reversible causes, like electrolyte abnormalities, say a severe drop in potassium can prolong the PR interval. When we fix the potassium, the delay resolves. This responsiveness to the environment, to vagal tone, to inflammation, to electrolytes, it shows that the AV node is functioning exactly as it should under stress. It is slowing down, but it is not blocked.
But it is exactly that responsiveness that makes it a critical clinical indicator. The fact that the PR interval prolonged during Lyme carditis was the flashing red warning sign that the myocardium was inflamed. Without recognizing that block, the carditis might have progressed unchecked to a fatal third-degree block.
Unmasking a vulnerability is not the same as the vulnerability being a disease in itself.
Structurally alters cardiac hemodynamics.
In extreme cases,
We've talked about how it causes pseudo-pacemaker syndrome at longer intervals, how it unmasks underlying conduction system fibrosis like Lev's disease, and how it serves as an early indicator for heart failure exacerbation. First-degree AV block is a real pathophysiological entity. It belongs in the AV block classification because it exists on the exact same anatomical and electrical continuum as the higher-degree blocks. Stripping the word block risks ignoring a vital early warning sign.
And my summary rests on the absolute definition of the physiology itself. Maintaining one-to-one conduction definitively separates this condition from true blocks. Every signal makes it through. The circuit never breaks.
But it pauses.
by calling it a block, we group a predominantly benign, highly common, and often vaguely mediated physiological variant into a category of severe arrhythmias. Treating a normal physiological response, like high parasympathetic tone, in a sleeping patient as a disease state is clinically misguided. The guidelines are clear. It's an atrioventricular delay. It's overwhelmingly asymptomatic, rarely progresses when the QRS is narrow, and generally requires no medical intervention.
I'll concede that a narrow QRS with a slight delay shouldn't cause panic. I think where we do find a strong point of convergence today is that context is everything when looking at the EKG.
Absolutely. We both agree that a patient with a narrow QRS complex and a PR interval just slightly over 200 milliseconds is largely demonstrating a benign finding that requires little more than basic observation.
Right. But I still argue we shouldn't strip the word block entirely, because if we see a wide QRS complex or a severely prolonged PR interval stretching beyond 300 milliseconds, we agree that requires vigilant monitoring and potentially intervention, as it points to that deeper structural highway damage.
Yes, the anatomy of where the delay occurs dictates the danger. The complexities of cardiac electrophysiology constantly remind us that our medical terminology sometimes struggles to capture the nuanced, dynamic realities of human biology.
It certainly does, which encourages all of us to look deeper into the mechanisms rather than just accepting a generic label on an automated EKG printout. There is so much more to explore when interpreting these rhythms, which brings me to a crucial resource for our audience.
Oh, absolutely.
If you want to dive deeper into mastering EKGs and truly understanding the structural nuances we discussed today, you need our EKG Survival Pack. It is an essential resource for listeners wanting to confidently interpret these exact rhythms without second-guessing themselves.
It really bridges that gap between the basic textbook definition and the complex physiological reality we've been debating today. Make sure this is a memorable broadcast for you by checking it out. It appears that listeners love the debate shows.
You can find our broadcasts on Spotify and YouTube. To catch our shows on schedule, don't forget to like, subscribe, and share our channel.
And remember, whether you call it a delay or a block, the electrical circuit of the heart is always telling a story about the muscle underneath. You just have to know how to read the timing.
Exactly. When you flip that light switch and there's a hesitation before the room illuminates, wait. Do you ignore the delay because the light eventually came on? Or do you start looking behind the drywall to see if the house is at risk of catching fire? We'll leave that ultimate conclusion up to you. Thank you for joining us.